meandering toward your seats so we can start on time. We'll be starting here in 1 minute. I wanted to make an announcement. I have two Fiora sets that were dropped on the stairs. If anybody's having a migraine from soccer practice,
I'll do my best to stay.
But anyway, you can come and grab them off my table here. And again, there was an iPad found yesterday. That is at the front desk, like back there. Our next speaker today is Dr. Michael Wheaton from St. Al's. He is a board-certified pediatrician who sees patients at the St. Al's Medical Group Garrity Clinic in Nampa. He is an experienced, accomplished, and published pediatrician with a history of caring for a primarily Latino patient population. He was raised in Plummer and even attended University of Idaho for a couple of years before going on to University of Massachusetts Amherst to get his bachelor's in zoology and animal biology. That probably transitioned nicely to pediatrics.
Absolutely. I thought I was going to be a vet, maybe. I don't know. I guess I am.
Yeah. He received his medical degree from the University of Washington and performed his residency at Cincinnati Children's. Before returning to Idaho in 2014, he practiced as an independent pediatrician in Charleston, South Carolina for a decade. He will discuss children's developmental disabilities and ADHD. Thank you, Dr. Wheaton.
You're welcome. Thank you for your time today. I've been in practice for over 20 years. Okay. Oh, it's probably still not. Yeah. Here. It's right here. Good. Okay. Here we go. So I've been in practice for over 20 years. I trained at Cincinnati Children's, as she had said. My first practice was in a small town in South Carolina called Walterboro. It's actually where they're doing the trial of Murdoch or whatever on the news right now. After working there, I really inherited a large number of very difficult ADHD children on the highest doses of stimulants, children on SSRIs and stimulants, antipsychotics and stimulants. It was really a crash course in the most difficult children with ADHD. Oh, bummer. Okay. All right. I'd like to talk to you really about a personal story. This is AJ. He's my son. Of course, with a pediatrician's child, occasionally we see things that are pediatric wise. He was a 21-month-old at the time. I noticed around 18 months that he really had minimal words, minimal talking. Up to the 15th month of life, he was developing normally. At that time, whoop, I went the wrong way. At that time, he was referred to early intervention in South Carolina. We call it BabyNet. Here in Idaho, they call it the Idaho Infant Toddler Program. I would like to talk briefly about that. In 1986, when Congress reauthorized the Individual Disabilities Education Act, they created the early intervention programs throughout the states. The states fund these programs, so individual states have more funding than others. But for my son, when the early interventionists examined him and to determine eligibility, this was the first time she had ever seen such a quiet kid. During his early intervention from 21 months to 33 months, he burned through 3 speech therapists. And by the 4th therapist, she noticed something called groping, I really did not understand what she had been telling me, and I will discuss what that particular thing is shortly. Whenever you have a child who isn't progressing through therapies as expected, we always should think about autism, of course, but also getting him to be seen by an developmental pediatrician. Alexander had great joint attention. He was wonderful, actually. And even as a pediatrician, that did not even cross my mind. But in this case, we did have to get him tested for autism. After the visit, he came out with 2 diagnoses: childhood apraxia of speech and ADHD. So this is very personal. When I look at developmental delays, I look at, it doesn't matter what diagnosis they come out of. They can have autism, they can have ADHD, but what we really need to work on is meeting their developmental needs. In the case of Alexander, it was his talking. One aspect of severe language delay is that they have lots of tantrums. They're very difficult children to calm down. And that's why sometimes we think of children who have severe language delays as being autistic or having other severe developmental disorders. In the case of Alexander, he actually, once he was adequately diagnosed, we had a speech therapist that was very adept at apraxia. In fact, in one session, he went from having really 1 or 2 words to saying knock, 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 and other things like that. I think it's very important to advocate for your patients. In terms of speech therapy, when you do have children who are not progressing through speech therapy, sometimes going for another program or another, for example, in Boise, Chatterbox, go to another site like Communicate, because there may be different speech therapists that are a better fit for your patients. The other important thing is the other diagnoses like ADHD under the age of 5, we really don't treat them with medications. We try to do cognitive behavioral therapy and those type of things. In terms of misbehaviors, parent-child interaction therapy is also important. I would like to talk about childhood apraxia. This is something that I had a very small amount of experience through Cincinnati Children's, but once I had a child with this has become a passion of mine to understand. It is a motor planning problem. So their signals in their brain go to their mouths, and that's the problem. It's almost like a stroke victim in terms of their brains are working, but they just can't get the words out. When I talked about groping, one of the examples I give is that for the word home, we use our lips and make an O and produce the vocalization home. Kids with childhood apraxia, with groping, tend to curl their lip, and it almost sounds like a stutter. It's more like home. And a lot of times, children with apraxia will repeat themselves. And part of it is they know it doesn't sound right. So they are trying their hardest to get the word out like it should be. We don't know the underlying etiology of childhood apraxia. It occurs about 1 to 2 per 1,000. We do know that ADHD is a big comorbidity of it. Roughly 85% of children with childhood apraxia actually have ADHD. The treatment of childhood apraxia is a little different relative to your expressive language delays and things like that, in that they need frequent speech therapy, 30, 40 minutes per day, 3 to 4 times a week, to kind of work on really learning how to use your mouth muscles, your tongue, to produce vocalizations. This is my little Alexander.
Go, go, go!
He used to run circles around us. I remember getting in the elevator in South Carolina in my hospital to go up to the nursery with him. And a gentleman was in the elevator and looked down at my son and looked at me and said, "There's no denying him. He's my mini-me." So the objectives of my talk are really to discuss the different aspects of developmental delays, psychiatric disorders, and how they're all intertwined with ADHD to some extent. I call these the ADHD influencers, and we'll discuss those throughout my talk. I'll talk about the neurophysiology briefly, the diagnosis, treatment, and prognosis of ADHD. I do want to state in terms of my talk that when I say attention deficit hyperactivity disorder, I'm covering all three subtypes that are known to be part of ADHD, which include the inattention subtype, the combination with hyperactivity, as well as the impulsive hyper subtypes. I do tell my parents when I discuss the evaluation of ADHD, because I think one of their biggest concerns are that my child is able to play video games fine. I don't believe he has ADHD. The school's pressuring me to get this evaluation. And what I try to kind of reassure the parent is that it's not truly a deficit. It is kind of a shame that we've labeled it a deficit, but it's more of a selectiveness. Their stimuli in their brain, they're getting all of those things just like you and I, but their problem is that they have a hard time prioritizing what's important. If they have video games, that's very important. They can do that all day long. But if it's a lecture on ADHD, maybe they can't. Again, I really believe this, that if we look at kids who get developmental delays or other aspects, all of these kind of are intertwined, intermingled, that we can't always tease out, well, it's just childhood apraxia or it's just ADHD. I think that's the most important thing, as with all of medicine, is that nothing is perfect, nothing follows the textbooks on how things should be. This is kind of my overall guide to this lecture. In terms of our lecture today, I want to go over some normal development. I want to start talking about developmental delays, and specific to that, autism, sleep disorders, psychiatric disorders. I did miss disruptive behaviors. We could talk about that too. CNS problems, lead toxicity exposure, as well as trauma and prenatal exposure. So normal development. So we all have had toddlers, or those that we've had kids or observed them. They're hyper, they run around, they're impulsive, they're inattentive, they're little tyrants. I always tell parents of little 2-year-olds, so is your child now the dictator of your household? Because that's what they are. It is very difficult when a parent comes in and asks whether their 3.5-year-old has ADHD. I tell them, I can't tell. These can be normal behaviors that tend to go away as they mature, and usually by the school year ages, it's not as big of an issue. But as you saw with my son, who at the age of 3 was diagnosed with ADHD, the only referral that I usually do is to go to a developmental pediatrician who can tease out those normal behaviors from probably more stereotypical behaviors of ADHD. One thing, I love medical history. When we talk about developmental delays, there was a doctor, Dr. Arnold Gessel. He was one of the grandfathers of figuring out the milestones of children. In the early 1900s, he was one of the first directors of the Yale Clinic for Child Development. He created this observational dome where he could observe and study children, and produced one of the first books that described the milestones from 3 months to 36 months of life. When we talk about developmental delays, we talk about really, and this goes along the lines of my well visits, I really look at their cognition, I look at how their socialization is coming about, language development, and motor skills. As you know, with cognition, it's how they problem solve, how they think, how they learn. In terms of socialization, how they express their feelings. And language, how they use their words, as well as motor, how they're able to jump around, climb on things, and those type of things. In terms of cognition, the areas where we start seeing this are children with, for example, chromosomal abnormalities like trisomy 21, genetic problems, brain abnormalities, those type of things. They all can produce some of those initial signs that we see with inattention. They can be inflexible with switching between tasks. Their working memory is poor. These are things that we start seeing as early as toddlerdom, but can continue with them through the school age years. One of the toughest things that we are seeing now in children are really the socialization disorders like autism. I would even put ADHD as part of this. I would put childhood apraxia as part of this, because really it's their ability to deal with the environment. A lot of times these are kids that have sensory problems. So they throw tantrums easily. Little problems create big reactions. Those are those things that we worry about with socialization developmental delays. In language, I look at language in 3 different aspects. I look at their receptive, their expressiveness, and their pragmatics. In terms of receptiveness, it's following directions. So if you have a child who isn't turning toward your voice during early infancy, we may have a problem with hearing. Those are things that we all have to address. In terms of expressiveness, starting sometimes as early as 9 months to 12 months, the babbling that starts. If they're not doing that, that could be an early sign of a possible language problem. In terms of pragmatics, and this is where my son has really had some challenges now that he's about 13 years old, is the back and forth conversations. He's the poster child of language delay. He talks, he interacts, but when it comes to the back and forth pragmatics of speech in terms of dealing with other children, you start to see that groping again. You start seeing his anxiety go up because he really has a hard time conversing for a long period of time. In terms of motor skills, we look at early infancy, we look at when did they sit up, when did they stand, when did they move around furniture, when did they walk. Those are the basics of gross motor skills. But specifically, especially like with ADHD, they can sometimes have handwriting problems. But other things such as hypotonia, muscular dystrophy, these cerebral palsy, those are things that start to affect how they move around, move their bodies in the environment. Autism, specific to autism, we don't know the reason more and more children are showing up with autism. The most current statistics show that 1 in 44, or roughly 23 children per 1,000, have autism. Autism is a spectrum disorder, so you can have children that are very high functioning, very interactive with the world, but still have some of those social deficits. And then you can have profound autism where they really have a hard time interacting with the world. ADHD is the most common comorbid diagnosis with autism. Roughly 50% of children with autism can have ADHD. A lot of people who have ADHD can exhibit some slight signs of autistic type behavior, but I think it's the whole intermingling of development that these children, because of their inattention or their inability to concentrate or respond to people talking to them, they can show those signs of, I guess they call them low level symptoms of autism. This is a fun one because these are those 3.5-year-olds who come into our clinic, and the parent asks, does my child have autism, or does my child have ADHD? Because they're running circles around them. They're driving the parents nuts. They're throwing fits. They're talking back. They're annoying their siblings. And I think the most important thing I get out of this evaluation is really, does this occur in more than one setting? Is this just occurring in the observation of the parents, and then when they go to grandparents, daycare, or school, they're angels? That, I think, is the most important difference between kind of a normal, difficult child versus a kid who truly has oppositional defiance. We do know teenagers, a lot of them have ODD at times. We do know that ADHD, about a third of those kids can have symptoms of oppositional defiance. And we do know that the treatment, the use of stimulants can actually decrease those symptoms. Conduct disorder. These are more extreme behaviors, as we know. They're the ones that are destroying things. They sometimes hurt animals. These are kind of those kids that do go on to sometimes have antisocial personality disorders, but they can also go on to have what we term disruptive mood dysregulation disorder, which I'll talk briefly during the psychiatric part of this. These are kids that are difficult to treat. Antipsychotics sometimes help, but for the most part, intensive therapy and knowing their backgrounds can help tremendously figuring these kids out. Sleep disorders. Sleep is very, very important. If we're chronically sleep deprived, we can start having signs of inattention, signs of daydreaming, those type of things. We do know that kids require a lot of sleep. If we look at toddlers, they require roughly 11 to 15 hours of sleep a day. School-age kids, anywhere from 9 to 14 hours a day. Teenagers, 8 to 10 hours. For adults, around 7 hours. And I always say doctors that are between the ages of 30 to 40, they need a lot of sleep. Doctors between the ages of 40 to 50 need some sleep. And us doctors over the age of 50 make jokes that we really don't need much sleep at all. So in terms of sleep disorders, sleep apnea is seen in children with snoring. We do know that in terms of treatment, 90% respond to a TNA, which is opposite of adults, where only 10% are curative after a tonsillectomy. There's circadian rhythm disorders. These are kids that just have a hard time falling asleep, staying asleep. This is very common with ADHD, though. Sometimes their minds don't shut off. Restless leg syndrome can be seen in kids with ADHD. There are some early studies that actually show that there may be lower dopamine levels in parts of the brain that can be related to restless leg syndrome. And there's sometimes, like magnesium can sometimes help with decreasing its effects. So, psychiatric conditions. I mentioned disrupted mood dysregulation disorder. These are the kids that sometimes are on those highest doses of stimulants. They are unruly sometimes. They'll throw a desk across the room. They can be sometimes put into extended resource. These are difficult kids, and I don't really have a perfect answer in terms of how we manage those kids, because I think they're the ones that are at the highest risk of going on to go into substance abuse or in sometimes the penal system. In terms of major depression, you all are seeing more and more of this as we are in pediatrics. In fact, I think I've written more SSRIs since my time in Idaho than my whole time I was back east and in residency. These kids have trouble with relationships. They can be inattentive, but they also have a lot of mood issues. They've had depression, they're sad. And that's the most important thing to realize, that a lot of these kids with depression have had this going on for a long period of time. It's not a short period of time. And those are those kids that we have to keep in the back of our mind and screen for suicidal ideation and HI as well. I talk a little bit about anxiety disorders too, because kids can present with OCD, separation anxiety. You can't see it, but I put in here tic disorders. Tic disorders really aren't anxiety disorders, but I do throw it in here because kids who present with tic disorders typically have a large amount of anxiety, and some of the ways that I have treated it are related to that, and we can talk about that during our question and answer session. Bipolar disorder, I have seen bipolar in kids. I've seen hypomanic teenagers. You know, I've seen them treated with lithium. I've seen them treated with antipsychotics. These two are kids that sometimes are a mix of the disrupted mood dysregulation kid and the bipolar, in terms of they're requiring large amounts of stimulants just to kind of take the edge off them. These are very difficult kids to treat. As you all know, lead is a neurotoxin. It actually causes, in high doses, actually not very high doses, 5 to 11 micrograms per deciliter can actually increase your risk of having ADHD about 63%. They present with inattention, all the real symptoms of disorganization. They actually have coordination problems. And one thing that I throw out there with kids who really have higher exposures of lead toxicity, they too are hard to treat. They aren't responsive to the stimulants that a stereotypical ADHD kid would respond to. When we talk about CNS disorders, we look at seizure disorders like epilepsy. We know that roughly 30 to 40% of children with seizure disorders can have ADHD. The two tumors that produce lots of catecholamines, like pheochromocytomas, paragangliomas, these kids can present sometimes with that inattention primarily, but if you look at their vitals, they sometimes will have more tachycardia, more hypertension, and a lot of times when they're treated with stimulants, those really become more of a factor in terms of their I can't talk today. Their symptoms worsening. I do mention within the CNS disorders trauma because traumatic brain injury, so shaken baby syndrome, those things can also present with inattention and problems during the school ages as well. We know now that prenatal exposure to the fetus to opiates, methamphetamine, as well as tobacco can increase your risk of presenting with ADHD during school age years. Well, this is kind of the boring part of the lecture, the neurophysiology. The main 4 areas of the brain that are affected with ADHD that we know of are your prefrontal cortex, your limbic system, your basal ganglia, and your reticular activating system. In terms of the frontal cortex, this is the area of the brain that's responsible for executive function. So it's your attention, it's your ability to continue to organize, those type of things. We know kids with problems with ADHD have deficits in executive function. Russell Barkley, one of the pioneers or psychologists in ADHD, talks about executive functioning, and it's a great YouTube to really watch if you are at all interested in looking at how these kids are affected with executive functioning. The limbic system is our fight or flight system. We know that kids with ADHD actually have smaller amygdalas. We know that in terms of the basal ganglia, these kids oftentimes will have lower levels of dopamine in this area. This is actually the area of the reward system. So we know that ADHD kids are really good with rapid rewards. They're really poor with rewards that are delayed. This is kind of related to this system here. And then the reticular activating system is our awake system. It's what keeps us alert and that type of stuff. And those are also affected by ADHD with deficiencies in dopamine and norepinephrine. Back to the neurotransmitters. Dopamine is our pleasure, happy hormone. We know that both norepinephrine and dopamine are rapidly reuptaked by ADHD kids. That's probably more part of the reason they have lower levels of dopamine and norepinephrine in their brains. This is also the site of where medications are active. In terms of diagnosis, all of us can diagnose ADHD. It is a fairly objective diagnosis. We sometimes can, of course, family history plays a role, genetics plays a role, but specifically forms like the Vanderbilt survey form, Connors, there's one, the ADHD RS4. All of these forms can help you objectively diagnose ADHD. Of those forms, the Vanderbilt forms are free. They can be photocopied. They can be given to the parents. The other forms require a fee technically for their copyright aspects. Again, we as primary care providers can make those diagnoses, but I also am dependent upon psychologists and developmental pediatricians who oftentimes will make a diagnosis, and that's how they present into my practice for treatment. To kind of go through the actual diagnosis, we definitely know in terms of adults, they actually need one less symptom relative to the inattention, the hyperactivity, the impulsiveness lists. Children between the ages of 5 to 17 need over 6 symptoms within those lists. These symptoms have to be present for over 6 months. They have to be seen in 2 settings at least, and really they affect all parts of their life. The symptoms of inattention, the daydreamer, the lack of following through with instructions, disorganization. These are all the typical symptoms we see with inattention. Hyperactivity. My child is one of the most hyper children I've ever seen, except my twin brother. He has a motor, and he just can't sit still. And I, as a parent, try to be as patient as possible with him. And I get it when a parent comes in and tells me their kid is very, very hyper. I totally get it. It is a very difficult thing as a parent to continually readdress their behaviors, even in your household. They leave their seat without when they're not expected to. They run around. They're really a very active child. Impulsiveness. These are sometimes those kids that I talked about, sometimes that present with a little bit of conduct disorder, the mood dysregulation, the bipolar. These are sometimes kids that are a little more troubled at waiting their turn. They're also the kid where they're standing in line and they flip off the hat of the kid in front of them. It was just an impulsive decision. They didn't really mean it. It just there was something in their mind that they had to do something like that. That was my twin brother. When I've made the diagnosis, I think it's very important that we move to start looking at the treatment plans for these children. Medications obviously are part of that, but parents often ask, what else can we do? Because I think we have to be versed in what is available to them and really give them the evidence to either support paying money for these things or kind of like, well, probably doesn't work that well, that type of stuff. I do say that once a diagnosis of ADHD is made, the first thing I do is I write a letter. I write a letter that basically confirms the diagnosis and basically asks the school to start the process of accommodations for their child. Because regardless of whether they choose to do medicines or not, we definitely need to get their educational system started in terms of accommodating them with their symptoms. So to kind of go through some of these modalities, and I've had personal experience with some of these things with my son. I have a firm belief that, coming from the background of taking care of those extremely difficult children, that we need to try to keep an open mind and consider other modalities of treatment as an adjunct to your medical treatment. So let's go over sensory integration training. They're the things that you see on the radio and TV, the brain balance kind of kid. Their idea, as well as this Achieve program that used to be part of Chatterbox, and then there's things like therapeutic listening. Vision therapy is also kind of in this sensory integration training. Basically, the idea is that if we treat kind of their sensory seeking avenues of their brain, their inattention will improve. So for example, if they have their kids that like to spin, their vestibular seeking, if we kind of train their brains to respond to that better, eventually as we go through this different training, those symptoms of inattention will improve. I myself, with my son, we went through the Achieve program. I think we spent close to $15,000 in 2 years. It didn't really help him. So I want to be a realist, because there are people who swear that brain balance is perfect. It isn't for everyone. So I always tell parents that, and I've also had patients come back to me from brain balance as well, and they started medicines. So it isn't a end all to avoid treatment. Neurofeedback is interesting. I did that with my son. So again, a lot of these modalities I've always thought about with my son. It is a form of EEG use. So they put on little electrodes on their head, and they have this interactive game that the observer kind of monitors their brain waves and creates a different scenario as he's playing this game. It actually helped. It did require weekly treatments, which was kind of a bummer, but hey, this was, this was before we put him on medicine. One thing that we had to discontinue neurofeedback is that he developed tics. And yes, you can develop tics naturally anyway, but every time he came from a session, his tics were horribly vocal, just terrible, that we really couldn't continue that. They would subside after a day, but we definitely knew that it was related to some of the neurofeedback. In terms of vision therapy, a lot of the optometrists in the area now are pushing kids who have some inattention toward this. I'm not convinced that it helps anecdotally. I don't know if there's a whole lot of evidence to show that this is also an end-all to avoid treatment for ADHD. Dietary changes, there's the Feingold diet, there's gluten restriction, there's red dye removal, there's sugar removal. I think if a parent wants to do restrictive dieting, they should try it. But I usually tell parents, do it for 3 months, do it for 6 months, and look at that, have an objective view of it. Like, here's what my child was like now, and what is he like after this? We did do some restrictive diet with my son. It really didn't change at all any of his behaviors. We did gluten restriction. That was really hard. You can't eat pizza as easily. And the digital treatments. This is kind of a new modality of treatment. There is a new video game that was recently approved called Endeavor RX. You can look this up. It's a prescription that we write to a pharmacy, and then they arrange the payment through their insurance or through themselves. And really, it's a video game that they play for 30 minutes a day, 5 times a week, that they have some clinical evidence to show less inattention hyperactivity. I'm still kind of on the fence with this. I prescribed it about 3 or 4 times already. I have not heard back from those parents yet. There's something called trigeminal nerve stimulation, and on Amazon, they also can get these brainwave devices similar to EEG type stuff that they can simulate wavelengths. A lot of those are all anecdotal in terms of their success. I do a lot of non-pharmaceutical treatment of ADHD because I think we have to, again, think outside the box that what we're doing with medications is not always perfect. These claims that supplements say they do or don't do really are not evaluated by the FDA. A lot of times there are studies that support their use, like omega-3s can improve inattention. In fact, there was a medical food that came in a capsule called Viarin that was on the market for several years that I actually had children really respond to that. They actually were on it for 2 or 3 years before we considered trying any type of stimulant in terms of their plan. We do know that omega-3s are essential fatty acids. They cover our nerves. This is kind of the whole idea, is we're optimizing the transmission of neuronal responses within the brain. Zinc they say will decrease hyperactivity. There's some studies that actually show that the use of zinc, probably around 15 milligrams to 50 milligrams a day, can reduce your total dose of stimulant as well. That is kind of anecdotal. I haven't seen that as much with the kids that I've treated. Vitamin D claims to actually improve attention as well. Iron is a component of dopamine and also has been implicated in improving attention. Magnesium is a muscle relaxant. It technically decreases hyperactivity. I've also seen it kind of slow these kids down during sleep. Finally, with L-theanine, it is a precursor to GABA, one of the amino acids, and technically we've seen them decrease their anxiety symptoms. It comes in a chewable tablet. They can take it 2 to 3 times a day and really can take an edge off of an irritable child as well. Yes?
How about methylfolate?
Great question. Great question. So that's going to be part of a pharmacogenetic thing that I was going to mention. So the studies for that really, for use of that, really aren't as robust as it is with depression or other psychiatric conditions. So I am still on the fence of that. I've had kids that take it, but I don't necessarily see that has been a major improvement in terms of their symptoms. So treatments, this is easy for me. This is what I do every day. We definitely have 2 avenues now. We have non-stimulants and stimulants. The non-stimulants really have less stigmata relative to our stimulants. I think one of the concerns that parents have when they come in for evaluations are that I don't want my child to be a zombie. I don't want their personality to change. I think back in the early days of how I was taught to treat children versus what I do now are completely different avenues on how I push dosing. When I first started treating children with ADHD, I was taught to increase the dose until they sat down in their seat. We definitely know now that those doses were probably higher than what were needed to improve their attention and performance in school than what we were doing clinically. We know with non-stimulants, there's less stigmata, less cardiovascular effects. They're longer lasting. For example, Strattera or atomoxetine can last over 24 hours. Stimulants, they're the gold standard. They've been used since the 1930s. There was a report in 1937 with the first use of amphetamine in children with a child who had hyperactivity and headaches. They were using the amphetamines to treat the headaches. It didn't work, but it sure helped the kid improve their hyperactivity and cognition. It was an interesting study that I read. We know that the efficacy of medicines is great. Roughly 70% respond well to the first agent used. The other 30%, probably the second or third agent. One aspect of things that I do want to bring up, and this gentleman asked me, is what do we do about kids who aren't responding as well, or those parents that are hyper anxious, they don't want to do medications, they don't want the trial and error of dosing. You can try pharmacogenetic testing. You can look at the different enzymes that are part of their body that metabolize different medications. So places like GeneSight, Genomind, those are areas where you'll take a swab of their mouth and send it off, and then they send you a report that, like for GeneSight, there'll be a green box, a yellow box, and a red box with medications listed. Those are sometimes very helpful, but they're also not the end all. I have had kids that actually did horrible in the green, but actually responded to a medicine in the red. So again, a lot of this stuff is still in their infancy in terms of knowledge base and also the testing of different enzymes that may help with your dosing of medications. I do feel like those kids that have had more challenges with medicines, and I do this pharmacogenic testing, sometimes it is very helpful at kind of explaining why they responded the way they did. The non-stimulants, atomoxetine, clonidine, guanfacine, and villoxazine is the newest of the non-stimulants. Strattera came about roughly in 2002. Clonidine, we've kind of used off-label in the past, but they came out with a long-acting version called Capvay that was FDA approved, as well as guanfacine in 2009, and villoxazine was just recently approved in 2021. I know some of you probably have had some crash and burns with kids on atomoxetine. I myself had as well. I remember in roughly 2002, 2003, the marketing of atomoxetine was that it would work as good as Concerta. I was excited. I remember I had those kids at the highest doses of stimulants. These are kids that are like, oh, finally I have something else in my toolbox to use. I crashed and burned. I took those kids off stimulants, put them on this, and oh my God, I thought they had challenges on the stimulant. Man, did they on Strattera. The advantages of atomoxetine really are that it lasts for over 24 hours. The disadvantage is it takes about 4 to 6 weeks to kind of kick in. It is weight-based dosing. When I crashed and burned with the use of Strattera, I stopped using it. I threw it out in my box. I stomped on the pills. I was done with it. But I continued to have challenges with the treatment of ADHD that I wanted to have another tool. So I grabbed it again and I started to throw it at my stimulant naive patients, slightly anxious and more inattentive. And lo and behold, I had some successes. In fact, even as of today, I have more than several patients just on Strattera, and they've been on Strattera now for 3-4 years without any treatment of stimulants. The major side effects that occur with Strattera and actually really limit its continued use are sometimes GI upset and somnolence. Clonidine and guanfacine have been around for quite some time. We've used it as adjunct therapy. Its thoughts of mechanism of action are that the effects are in the prefrontal cortex and mimics the effects of norepinephrine. I find that these two medications help more with the impulse control, meaning that kid who was going to hit the hat off the child in front of them, it may give them a second to think about what they were going to do, and hopefully they take the road of not doing it. I do find that, and Capvay especially, clonidine actually serves more as an adjunct to my use of stimulants, and that it can sometimes help them with their sleep as well as sometimes even their impulse control throughout the day. The newest medication, villoxazine, Quellabri, it actually is an interesting medication. It's a serotonin norepinephrine modulator. And if you guys know as well, so is Cymbalta. So it's interesting that this has come out. It was used as a antidepressant in Europe from 1974 to 2002. It was taken off market there for unknown reasons. and then came to our market in 2021 as a treatment for ADHD. The onset of viloxazine is roughly 2 to 3 weeks. It's not as long as it takes for Strattera to kick in. Its effects primarily kids with anxiety, with ADD. I have not had as much experience prescribing this only because of the third-party payers not wanting to pay for them. The stimulants are our gold standard. We all know how to use methylphenidate, the mixed salts of amphetamines. Methylphenidate blocks the reuptake of norepi and dopamine. It also causes the release of the dopamine and norepi into the neuronal spaces. We do know that they've done a great job at giving us different forms to give to kids. You know, you have your typical tablets, capsules that can be opened, sprinkled on applesauce. We now have long-acting suspensions, long-acting chewable tablets. Really, it has made the treatment of the smaller children, like at the age of 6 years old, much easier in terms of offering something to those parents. Some of the novel formulations to be aware of: Focalin was an osmotic release tablet. Focalin is an isomer of methylphenidate. Quilichew is the chewable formulation. Quilivant, a suspension. And one of the newest formulation is Jornay PM, which is actually a kind of cool technology in terms of you would give it at nighttime and it becomes active in the morning. So those kids that you have a lot of trouble with the morning shuffle, like, oh gosh, I forgot the medicine, or they're just total terrors until sometimes the medication kicks in. This is an option to think about. And third-party payers do pay for this if they've been on like your regular Concerta or something like that as an option. Amphetamines have been used for quite some time. There's been various forms of them. As it is with methylphenidate, they come in capsules, tablets, chewable tablets, extended release. Vyvanse is one of the kind of isomer first pass kinetic derivatives. It is actually interesting that the capsule itself can be opened, the powder sprinkled on a teaspoon of water, it completely dissolves, and they can take it that way. It's tasteless, so that's always an option. Most third-party payers allow you to prescribe that first line. But Vyvanse also comes in a chewable tablet. There are extended release suspensions, which are a little harder to get paid for by the third parties as well. What is our prognosis? I was always taught that roughly children who are started on medications, about 2/3 by the time they finish high school will not need any medication. I don't think these symptoms go away. I think they learn to deal with making lists, they learn to deal with their inattention, but I also think that there's some evidence to show that there are a group of kids that go in complete remission, and they say that roughly 10% of those kids, but I do think that roughly 20 to 30% of people with ADHD likely will need some type of treatment during adulthood. So where do these kids end up? Where do adults end up with ADHD? My twin brother is in sales. That guy, I always thought I was an introvert. I'm not, but if you meet my twin brother, you'll think I'm an introvert for sure. He can sell anything. He sold, used cars. He sells applications to credit unions. He cold calls people. He is definitely the extrovert of the two of us. But these kids with ADHD, they're creative. They're the people who sometimes think outside the box. Those are the kids with ADHD. In summary, I want to say that ADHD is commingled with all of these disorders that I talked about. Some can be specifically divided from ADHD, but others you just can't tell. They have certain characteristics that affect them throughout their school-age years. Diagnosis of ADHD can be done objectively with survey forms. The brains of ADHD are unique. And finally, as I said, close to 2/3 of children who are treated will likely not need any treatment during adulthood. I do want to say one caveat to that parents ask me all the time, what if I don't treat my child? We do know that children who are untreated actually have higher risks for substance abuse, higher risks of having accidents, those type of things. So it's something to realize that the lack of treatment of ADHD can eventually cause more problems than most parents can realize. I do think in terms of treatment strategies, we have to have a toolbox of many different ways we can treat this. I think we do have our gold standards, stimulants, non-stimulants, but we have to think outside the box in terms of the use of supplements and these different modalities like neurofeedback and things like that, and especially in parents who are very hesitant to consider medication. I try my best to convince every parent to consider medication, but a lot of times they come in for the diagnosis to get accommodations for the school more often. And that's my talk.